Good afternoon and good morning from Washington, D.C. I hope everyone is doing well. Thank you so much for inviting me to talk to you about postpartum depression in the NICU. Wanted to talk to you guys about the work that we've been doing over the last 5 years here at Children's National, both in the neonatal and intensive care unit and in the emergency room, on behalf of Dr. Jarvis, and also on behalf of the Perinatal Mental Health Task Force, which is a group of 40 dedicated clinicians, including social workers, pediatricians, NICU docs, emergency medicine docs, psychologists that do this work in our hospital at Children's National in DC. I wanted to show you my disclosures, but also to talk to you a little bit about the tremendous effort, not only that goes into it, but also the faith that the funders of this project over the last 5 years have instilled in us. And it's the funding for a lot of these projects is coming not only from the government, but also from internal grants within the Children's National, and also from private donors who are very interested in the interaction or the global work on both maternal health and children's health. And one of the things that you're going to hear from me consistently is healthy mothers, happy babies. So in order for us to get good outcomes in the NICU or in the children's hospital, we also need to take care of the families, in particular the moms and also the dads. What I wanted to talk to you about is something that for a lot of pediatricians and neonatologists may not be directly in the scope of your work. But I wanted to make the case for why it is important for you to pay attention and to get ready for taking care of postpartum depression. We'll talk a little bit about the prevalence and also the risk factors, but I also wanted to walk you through some of the strategies that we've applied in our NICU and in our hospital to support parents during and after their NICU stay. I wanted to start with a case, and this was a real case that happened. It happened to circulate a lot amongst our task force and amongst our group, and it relates to a mother who had just had a normal baby, was going to her obstetrician about 4 months out after the birth, and she was feeling these symptoms of anger and violence, and she recognized it herself. Called the nurse practitioner, told them a week in advance that she's coming in, especially for postpartum depression, and was very upset when the provider went in. And what ended up happening was the mother ended up being escorted to the emergency room after the police were called. And it kind of struck a chord with us all. A lot of things could have gone right in this scenario, but a lot of things in this case went wrong. And she happened to post it on Facebook in 2018. And you guys can read her comment. But it highlights to us something that, when I was preparing this talk, something that kind of, that resonated with me. Why are you interested? Why do you care? You know, the OB is going to take care of it. And what happens is, you know, we're starting to realize from our experience that, first of all, a lot of the obstetrician offices aren't fully equipped to deal with postpartum depression. Number two, that it can go on for a while, 3 to 4 months. And a lot of the times, the 3 to 4 months for a NICU baby, they are spent with the parents, with the families, with the baby in front of our eyes. And then the third chord was, you know, we really don't have a good system to manage, and we don't know what to do. And is there a role for education or setting up systems that would allow us to handle this condition a lot better than we do? So not only are the patients telling you how bad they're feeling, but it's also been a feature in our news here for a while now. And you can see these are articles from the Washington Post, from CNN, and from National Public Radio. And they're very recent, all the way up to 2018, 2017 and 2018. And a lot of these stories revolve around mothers who have committed suicide or have actually died because they're not getting the attention that they need. and the opportunity for us to screen moms and how we're gonna get that done. And it's not only, again, the OB's issue, like the American College of Obstetricians and Gynecologists has issued strong statements, but also the American Academy of Pediatrics and Family Practice, they're also issuing strong statements around screening for postpartum depression. So it's on all of us. Let's put it into perspective. When you think of postpartum depression, if you start off with major depressive disorders, where in adults, both men and women, the incidence is about 6.7%. In general, that translates to about 15 million adults, both men and women, who will suffer from depression in general. Over a woman's lifetime, she is probably twice as likely to have a depressive disorder or depressive symptoms than a man. When you look at the postpartum or the peripartum period, so the third trimester and going into the first 6 months and even the first year after birth, the incidence is about 15%. So about 400,000 women a year will develop this condition. And then add to that the stress of being in the NICU, both full terms and preterms, preterm kids, and the incidence rises to about 28%. And there is literature, several papers out there noting that preterm moms tend to be more affected than full-term moms, and the incidence then rises to about 33%. And to put it into context of, for you guys, even for looking at our current situation with COVID, the incidence of COVID right now is about 5%. So this isn't a small, in general, it isn't a small proportion, and you're very likely to have run into this in your NICU or in your hospital, and you may or may not even have recognized this going on in the mom. If you put that into context, so the 15% of peripartum depression, if you put that into context, it actually looks like 1 in 7 women. And again, ACOG has issued clear guidelines that at least once during the perinatal period, pregnant women should be screened. So what does it look like? What will it look like in your NICU? So again, we're looking at the picture of, a young woman who's just given birth, and, this is what she should really look like. She should be happy. She, her partner's there, life is good, the 9 months are over, and everyone should be feeling happy. But unfortunately, with postpartum depression, a lot of these moms, that feeling is of guilt. They are feeling that because I'm not having those feelings of happiness and joy, that there's something wrong with me, and that's kind of what we're talking about. I wanted to take a moment to differentiate between something that commonly you will see, it's called baby blues. About 50 to 80% of women will have this after childbirth. About 5 days after delivery, they start to feel that they are tired, they're irritable. It relates a lot to kind of adjusting to breastfeeding, adjusting to, if you've had a C-section, the pain of the C-section. It's temporary, it's mild, it doesn't interfere with caring for the baby, and it kind of tends to dissipate after. So that tends to be one end of the spectrum. We call that baby blues. It's very transient and usually not something that moms will report. And this is also one of the reasons why we don't screen for postpartum depression that early. On the other end of the spectrum, you will notice that there is something called postpartum psychosis, and this is a very rare condition. It occurs in 1 to 3 out of every 1,000 women. And usually associated with a history of bipolar disorder, and will manifest with paranoia, hallucinations, delusions, and even suicide or homicide at that point. And those are the stories that usually make the headlines and will be reported in the press. But again, those tend to be very rare. What we're talking about is essentially postpartum depression that is kind of midway in the spectrum of all of that. And as you can see, this is a laundry list of symptoms. You can touch on any of those and say, well, irritability, that's normal. Not sleeping, that's normal. The difference is this one tends to persist. You start seeing it at around 2 weeks of age, and then around a month, up to 6 months, even up to a year after the baby is born. And a lot of these mothers, they think that they're going crazy, that they think that this is abnormal. they look at the mothers around them and feel that, that something's wrong with them. And this is essentially kind of the crux of postpartum depression. What does it look like for you in the NICU? It takes different forms. And one of the reasons we were interested in looking at it was essentially because a lot of the parents were manifesting in different ways, and it created a lot of tension with the staff. So the mother that comes to you and doesn't engage, doesn't come to the NICU, doesn't want to take care of the baby, is withdrawn when you talk, is also not showing a lot of emotion when you're kind of disclosing how sick the baby is, could be one way to go about it. And then the other is also, you know, the incessant crying, or even the combativeness, feeling helpless and trying to gain control, and again, being very combative with the staff. Unrealistic complaints is another way to put it out there, and that's kind of what we were noticing in our unit, and what drew us more to kind of dive into whether parents are having postpartum depression. Again, it's both moms and dads, and trying to figure out what we can do to help. Now, mind you, postpartum depression is under a big umbrella of something called perinatal mood and anxiety disorders, PMAD for short. Perinatal mood and anxiety disorders also include anxiety, stress, post-traumatic stress disorder, obsessive compulsive disorders, and then again, bipolar disorders as a major depressive symptom. So we're only talking about the postpartum depression here. So being in the NICU adds additional stress, and the way I like to think about the risk factors include having additional, in 3 sections. The first is stressors that add to your baseline. Preterm births and NICU admission being the 2 most common at the top of that list. Financial stressors and unintended pregnancy have also been noted in the literature. One of the things that our social workers do when we have a family coming in, all our families get screened, and part of the intake process also involves understanding if they have a history of depression and anxiety, or if they're on medications. That kind of gives us also a good sense of how to help. And then you will notice the third pillar of that is the low social support. So having marital issues, having a non-supportive partner, not having family around, which I think also kind of speaks to a lot of families that are in the area that all of a sudden found themselves away from the grandmother and the grandfather and all of their family supports. And I think this also resonates in the UAE, where you have a lot of folks that are expats that are coming in, and maybe they don't have the social support or the friends or the family that they had at home. And then another big one is having low household income. And this is a huge risk factor because these moms do not have the means to get a babysitter or the luxury of other supports that they can do. Getting online, getting into support groups kind of are another example of where low-income families are at a disadvantage. And each one of these factors is additive. So you can have a preterm birth and low social support, and that adds more and likely increases your risk of getting postpartum depression. Why do we care? We care because it does affect the mother, and it also affects the child. The first way that you're going to see it in the NICU is the breastfeeding. They don't want to breastfeed. They don't want to give milk, and that's kind of our lifeline. This is the one thing that we need the parents to work with us as a team. And then the other one that I wanted to highlight, which is the risk of major depression. So if you do have postpartum depression, the likelihood that you're going to go on to develop major depression is high. It's also recurrent. So with the next pregnancy, you're also going to be seeing that in the mom. And then there are long-term effects on the children. So if we take it the other way around, so if you're stressed and depressed during pregnancy, you are at risk of having a preterm infant or a low birth weight infant. Later on, it manifests as child abuse and neglect, withdrawal and avoidance in the toddlers. And again, it goes all of the way up to school outcomes and reading. And here it's also notable that dads that are depressed also will affect their child's school outcome. Again, it relates a lot to the home environment and how we're interacting with these kids as they're growing up. We know that they have twice the rate of physical problems, and 50% of the adolescents will go on to have psychiatric disorders. And then the worst outcome, or the saddest outcome of all of that, is postpartum depression that has not been recognized and has led to a maternal suicide, a mother that takes her life because she's that depressed. When you look backwards at the literature in a study from the University of North Carolina, they've noted that maternal deaths, when you look at the etiology of maternal deaths, about 20% of the postpartum deaths are related to suicide and an unrecognized state of postpartum depression. So currently, what is the recommendation? The recommendation from the U.S. Preventive Service Task Force, ACOG, and the American Academy are to screen parents for postpartum depression. And the underline here is parents, both moms and dads. And these follow your regular visits at 1, 2, 4, and 6 months, and use standardized questionnaires. But unfortunately, we're not very good at doing that. And we know from recent studies that only 44% of pediatricians are routinely screening. And even after you screen and you counsel the mother, only 15% of those that are high risk are actually going on to get behavioral therapy or getting connected with a psychologist for help. So again, how does this affect me in the NICU? What are the barriers that NICU moms face? So again, we're pediatricians, but I don't have the 1, 2, 4, and 6 month visits, and I probably don't have the luxury of kind of having the referral system. I may or may not have it. So a lot of the barriers when talking to my colleagues, one of the barriers that usually come up are that only 20% of their mothers go to a postpartum visit. And this is on a normal day in a regular baby who's not a NICU mom. So the NICU moms are going to miss their postpartum visit at 6 weeks because the baby may still be in the unit. And therefore, you know, she's not going to the postpartum visit. She's not going to the pediatrician. So no one is screening. The second thing that we have found to be very profound is that you can't tell by just talking to somebody whether they're depressed or not. And this is with even the most seasoned social worker that we have. And we've had situations where until we started screening, we weren't aware of how the mom was feeling or what was going on. So if you don't ask, they probably won't tell you. The common argument is that, you know, the clinicians don't have time to screen. You know, I'm running around, I'm taking care of kids on ventilators. When do I do this? And who does it? Is it the physician? Is it the nurse? Or is it the social worker? I may not have, you know, somebody that is trained to do it. And most importantly, what do I do with the results? So now what? I've screened. What happens after? I don't know what questionnaires to use as a common one. Here in the US, a lot of the time, we always ask about reimbursement. So a strong motivator for people to screen is essentially, can I put this on my reimbursement? Will I get money back for doing this in my visit? And then the common one that pediatricians also face is the visit is too short. There's too many things to do. I need to do a lot of counseling with this mother, especially if she has issues with feeding, with lactation, with you know, routine care of the baby, that I may not get to that. So this was published by the American Academy, ACOG, in 2015, and it gives you a sense of some of the screening tools to kind of tackle that first barrier. The one that's commonly used, and you'll see in the literature and in clinical practice and in research, is the Edinburgh Postnatal Depression Scale, and it takes less than 10 minutes, and you can see the sensitivity and specificity of that one. It is available in Spanish. It's also available in Arabic. And that one, we have a lot of experience with it. The problem with that screen in particular, the last question on the screen asks about suicidal ideations. It asks about suicidality. So I always caution with that screen that you need to have a plan in case a mother answers anything other than never to question 10 on that screen. And that's kind of where it gets interesting when you're thinking about setting up programs to routinely screen in the NICU or in the office. The other one that we've had a little bit of experience with is the Center for Epidemiological Studies Depression Scale, either the 20-item questionnaire or the 10-item questionnaire. And that one is doesn't have a suicidality question, and also mirrors the Edinburgh postnatal depression screen. It's also another tool. And also the Patient Health Questionnaire 9, if you're thinking about it, is a good one to use. And here is the Arabic version. This was a study in 1997 that validated the Arabic version. It's available online. I'm happy to kind of share the links if you guys would like it. It was conducted on 95 mothers at 1 and 8 weeks postpartum, and they found that the sensitivity and specificity to other depression screens was pretty decent, and it is available online. There's also some calculators if you guys are looking for something that's quick and not in paper form. So what did we do with that? What were the next steps? So again, you're going to start screening. So that's step one. But what's going to happen? So I wanted to walk you a little bit through our journey with the screening, because that's not kind of where we started. So we started off in 2015, 2016, actually doing a randomized control trial where we were looking at babies after, mothers and babies after they go home. And our question was, would we be able to decrease depression and stress post-discharge? So our question focused mainly around not NICU interventions, but after NICU interventions. And we thought that addition of a peer, so another mother who's been through a lot of the NICU issues, and frequent contact with the mothers within the first year after discharge, would essentially decrease a lot of these mood and anxiety metrics, and would also improve outcomes such as immunizations and behavioral outcomes using the Bailey scale. We did a pre-discharge survey and medical chart review. So our study essentially started at the time of discharge, and we used this SD. We also looked at stress, and we analyzed the results. And to our surprise, we found that about 45% of our parents at the time that they're leaving the NICU. So again, we all think that the NICU is stressful, and the time to have depression or stress is while you're inpatient. But that was not our finding. When we tested them at discharge, about 45% of them had elevated screens. They scored more than 10 points. And this was essentially associated more with parents of female infants. Unlike what the literature says about, mothers of preterm infants having higher depression score, we found that in actual fact, we found term infants being 7.87 times more at risk of suffering from depressive symptoms, and then near term 5 times as much as mothers who had babies less than 28 weeks. We also found a good split between men and women. So if you had an elevated score, men and women were equal in that sense. And we also found that length of stay may slightly increase your odds of having depressive symptoms. And when we looked at it, discharge from the NICU can be before the 2-week mark. And we were trying to screen out those that had baby blues and those that went on to have actual positive depressive symptoms. And we noticed that if we screened within the 2 weeks, 48% had high scores, whereas if we screened after, about 43% had high scores, which also kind of corroborated the fact that our mothers, or 45% of our mothers, are screening positive for postpartum depression. And like I said, postpartum depression, or PMADS, is an umbrella. Stress and depression go hand in hand. So for every 1 point increase in stress, you also get a measurable increase in your postpartum depression scores. So on average, about 2.3 to 2.6 points on the stress measure, on the postpartum depression measure, for every 1 point increase in the stress measure. Good news is when we looked at it over time, from months of discharge, we noticed that the two groups are two control and intervention groups. They mirrored almost each other. And that around 6 months after discharge and all the way down to 12 months, the symptoms will fade, they will dissipate. So there's hope. This is not something that kind of keeps on going on. The bad news is we didn't find that our peer-to-peer support intervention made much difference. It just naturally declined on its own. So in conclusion, we found that there was a high incidence of 45% of NICU parents experienced depressive symptoms, and it was associated with parental stress. The other thing that was inversely correlated was low social support. So mothers who had high depressive symptoms tended to have lower social support. And that got us thinking about the next steps. So now what? So we've screened. What are we going to do about it? The way that we handle it in our unit is any mother that screens positive is now given some counseling. He's given some resources. We've developed a mental health resource sheet. We encourage them to enroll in Postpartum Support International programs, to go to our local providers. And then we've also realized that we can't just hand off, but there also needs to be after discharge support, which we're hoping that the Postpartum Support International and referral to psych services will help with. And we also noticed that we need to do more. And there are many strategies out there in the literature looking at stress reduction within the NICU, and that those programs are trying to build resilience in the parents and trying to boost the maternal and paternal confidence while they're in the NICU. So that carries over to discharge after at home. Unfortunately, not a lot of studies are doing longitudinal follow-ups of NICU strategies and outpatient strategies. So that's kind of an area that's ripe for research. The other big step that we found was very helpful was collaboration. And I wanted to show you the work that's going on across our institution. So we noticed that screening occurred in multiple settings. The biggest two settings are the NICU, the emergency room, and the primary care pediatrician's office. And we were doing this work independently. So each person, each one of my collaborators was working in their silo without knowing what I was doing, without knowing what the others were doing. So we developed a perinatal mental health task force based on the social ecological model. And here we wanted to elevate from just doing individual screening to looking at interpersonal organization, community, and policy ways to amplify our work. So in the primary care setting, our clinics, you can see 5 clinics here. They set out on a goal of completing the Edinburgh Postpartum Depression screen at 2 months. They started this work in 2016, and they went from rates of 0 to 20. You can see up to 80%. So in these in this setting, our clinics are now all the way up to 2,000 now. We're screening all our moms that are at 2 months of well child check for postpartum depression. Their screening rates for positivity are about 12 to 20%. Similarly, in the emergency room, this work was started in 2016, and you can see that that 209 patients were screened in the study, but subsequently after that, we continued to screen, and our positivity rate is 27% in the emergency room. About 7% of the mothers and 4% of the NICU mom, 7% in the ED and 4% of the NICU moms are screening positive for suicidality. This tells us that we needed to put more resources, and we have more social workers. We've got more resources now than ever through a combined effort. We've developed a manual that translates across all parts of the hospital. We meet monthly or bi-monthly to come up with strategies. We've actually unified our cutoff scores so that way we can compare across venues. On the organizational level, the Mental Health Task Force took up the screening, has developed resource tools. We're starting to develop connections with our providers in the community, so we know where to refer. Unfortunately, one of the barriers that we often come up with is a lot of these programs don't have space for our moms. So the mother could be on a waiting list for 4 to 6 weeks, whereas we all know that she needs immediate treatment within the week or 2 weeks at most, and that's starting to become a barrier. So we're looking at training and educating our providers in-house, providing more psych services within our pediatric hospital. We've also been able to share best practices amongst ourselves, share data, share screening protocols. We're currently tackling the billing and coding. So again, inpatient is a little bit different than outpatient, where we the way that we bill is bundled. So if we do anything extra, we're actually not getting credit for it. And we also wanted to reach out and develop cultural competency within our hospital. Community level, we developed a provider toolkit in 2017, and this is accessible to providers in Washington, D.C. And we've also had the opportunity to develop some training courses and participate in training of providers in the community to reach out to primary care pediatric practices that are outside Children's National. And we've tried to integrate with them to have mental health integration in primary care clinics. One of the highlights is the Healthy Steps. And here we're aiming to embed psychologists in our primary care clinics to identify and treat PMADs. And policy-wise, we've sent several representatives to Congress and to our DC local government to advocate for Medicaid reimbursement. And we've been fortunate within the last couple of years that the US government has issued several acts that allow for support of postpartum depression screening efforts, and also for the local governments have also supported our efforts, and we continue to push on with that. So in conclusion, our current approach to PMADs includes screening, referral, and linkages for these mothers. And our hope, again, is to screen and support mental health and support healthy infants and development. Specifically, you're going to ask me in the NICU. We collaborate with Perinatal Mental Health Task Force. We've got 40 providers. We've gone on to include now the Cardiac Intensive Care Unit. We are aiming to increase our universal screening from about 20% of all parents to about 80% of all our parents, including moms and dads, including both English and Spanish speaking. We have a study going on right now looking at the relationship between the postpartum depression and resilience. And our theory here is if we increase resilience, depression will decrease. We have a lot of discussions around crisis management and how we are going to manage the mom that's in crisis within the unit, within the NICU. We've hired more social workers and more support personnel. One exciting thing that we're going to be doing within the next 6 months is we're going to be offering psychological support through a trained licensed psychologist in our unit. And that psychologist will also be able to do remote screening and telehealth follow-ups. And we continue to have our parent navigator to provide peer-to-peer support. Our resource guides are continually being updated, and we're offering more provider training to our nurses and frontline. And this is kind of an example of some of the support, some of the resources that we're providing. Thank you so much for your attention. This has been wonderful. Thank you for spending some time with me this morning.